Can you see my desktop?
Yes, I can see your desktop. Absolutely. As I know that there's not a lot of time for you, by all means, go ahead and start. I'll keep admitting participants. Yeah.
Okay. Yeah. Thanks. Thank you for giving me the opportunity to present.
Pleasure, pleasure.
Yeah, I mean, this was one of I'm pretty sure it's the right case. Yeah, one of a few interesting cases that I did long ultrasound scans on, and it felt good to do this scan because the timings that I did this scan helped guide and improve guided clinical care that we're able to provide for the baby. So this was a 34-weeker. I did a scan on day 6 of life. But the background history was there was antenatal diagnosis of anhydramnios, the suspected lower urinary tract obstruction with rupture of the ureteral cell. They were quite concerned about this baby, so they gave antenatal steroids and magnesium sulfate. And the baby was born by cesarean section in poor condition, was intubated immediately and given a dose of Curacef. And as you would expect, with the background history of anhydramnios, we were prepared for PPHN and all that would follow, and it all came. So was intubated, was in 100% oxygen immediately, giving Curacef. As we didn't even wait to do an echo, we just started nitric, and following on after the echo was done, started sildenafil, adrenaline, and it wasn't surprising that the baby developed the right-sided pneumothorax and had a chest drain inserted. Now, this all happened before day 6 of life. Baby was noted to be hydropic at birth. At the time I was doing this scan, baby had the oxygen requirement had come down to 50%. We diagnosed bilateral hydronephrosis. There was a male baby, so he had posterior urethral valves, and so the chest drain was inserted. And then by day 6 of life, because of how unstable the baby was and the fact that baby was in a lot of oxygen, the team was not entirely sure that the pneumothorax was resolved. So I probably came forward. Hello.
Yeah, now we've got you. I've muted the others. Don't worry.
Okay.
Go for it.
So
Yeah.
I did this ultrasound on day 6 of life to check to see if there was still a pneumothorax so that the team could make some progress. So these are the x-rays which I thought I would share. The first x-ray on the left is the x-ray after birth. As you can see, the baby had the right-sided pneumothorax. You can appreciate how hydropic the baby looked with massive ascites, and there was also some pleural effusion. And this was the x-ray a few hours before I had done the ultrasound. As you can see, the pneumothorax appeared to have resolved on the x-ray, but because he was doing a lot of oxygen, the team were not entirely certain that the pneumothorax had resolved. So it was on the premise of this that I followed up with an ultrasound scan. So it was a bit of a challenging scan because of how the baby was positioned and how the massive ascites, and hydropic the baby was. So my views may be a little bit limited. So I started with the left because that was where I was positioned. As you can see, the pleural is continuous. It does look a bit thick, but it is regular. There is pleural sliding, as you can see. You can see you can see comet tails. You can see few A lines, but mostly it's a B profile. This is the upper side. So on the lower side, it was a bit challenging doing the scan because, as you can see, the abdominal organ is coming into view, and you can see this is part of the ascites.
Yep, yep.
I'll take care.
Actually, it is most probably the spleen with the ascites. Yeah.
Yeah, that's what I thought, because this is the left side. Yeah. So but the aspects of the lungs that you can see, the pleural looks continuous. Oh, just a minute.
Just Reggie's having a blood transfusion.
I'm so sorry.
Don't worry, it's all right.
Yeah. Okay, so the pleural, there is pleural sliding, as you can see. You can appreciate some A lines, but mainly B lines. Clearly from this view that I got. So I tried to, try to get more of the lungs by moving my probe a bit. This is still the left lower anterior lower view. And but you can see, looking at the lungs clearly, there is pleural sliding. The pleural is regular. Some A lines, you can still see B lines. So I think more B lines, which I'll class as the B profile.
I would agree.
Yeah,
A very interstitial kind of an appearance.
absolutely. Yeah.
With a dominant B profile, some A lines, it's a little bit better aerated than the previous one. So, yep.
Yeah.
And the left lower again, dominant B profile. You're just starting to get compact B lines now because the B lines are kind of coalescing. So,
and this is on the lateral side. So anteriorly, the lungs look more aerated than the lower lateral side, which you can see clearly with more of compact B lines, like I've seen clearly. And this is still more of the same view, left lower lateral views. Now, going to the posterior view, which I took at the posterior axillary line, you can appreciate the pleural looks thick. So there is pleural sliding very clearly. Compact B lines, I couldn't see any A lines. The baby's line supine. Yeah.
So the thickness of the pleura might just be because you're not quite at 90, as opposed to being truly thick. And actually, when you go to your next image, it is. So we'll just look at the next set of images. You can see how blurred the pleura looks, and it's not really, in my opinion, likely to be irregular. It's just the fact that you're not quite aligned at 90.
Yeah.
Then you've got what I think, is that the heart, or is that the abdomen still?
And this is the posterior, the left side. So I think this is more of the heart coming into view.
Yeah.
With part of the occlusion also that we are seeing. So going to the right.
So just on that posterior left lower area, as described, the jellyfish sign.
Yes.
So distally, and I mean, that bit in the middle that you see floating, that looks separate to the lung. It's more the edge of the lung. Go superiorly. No, above that, that edge. That is the jellyfish there.
Oh, this not the
okay. No, because so this sickle-shaped area is basically the lateral edge, and you have fluid below that. So whether this bit in the middle, that tissue, could be a part of the lung is difficult. It doesn't have continuity. Maybe it's just the angle at which you are, but you have a decent diffusion there. Yep.
Yeah.
I think what it goes to emphasize is, as you move from anterior to posterior, you can see that there's no fluid anteriorly, but because the baby's supine, the small amount of fluid that there is has actually really accumulated in the posterior, most left lower recess. So very nice.
Yeah. And then moving to the right side. So there are the right upper, anterior upper region. So the pleural looks. This was quite interesting. This bit was the pleural looks thick, and I tried to make sure it was well positioned. My probe was well positioned, and I kept adjusting the probe to find out what this was, because there was just no continuity after this. And so I was worried why the pleural, why this was. So I was wondering, anyway, for my next, let's see what the next view is. So
is that atelectasis?
That's my thought.
Because what has happened is that you've basically got on the right of that image, pleura that's linear. Then you lose your pleura between that rib space. And the question is whether those might be just static air bronchograms that are trapped. And then that area there looks like a classical tissue sign.
This, isn't it?
Yeah. So, I mean, it would be interesting. Should we just go back to your x-ray?
Okay.
It'd be very interesting to see whether. So can you see that area there, the right upper lobe? Yeah. So you've got a collapse there. So I think that's what you're probably seeing. So very nice image, Doris. Very good gain settings and nice depth penetration. So we can see and understand things very nicely. Carry on, please. Sorry to interrupt you.
No, please do interrupt me. I'm really pleased that you're doing that because I was really worried what this was. And even though I couldn't see what this area was.
Here you've got dropout because the rib space is coming. So you've basically got an acoustic shadow. And that is the challenge of going in a very small baby into the right anterior upper region. It tends to fall away from your probe. So it's never easy. But that's how they are actually visible. So very nice image. Yep.
Yeah. Thank you. So moving on to the lower right anterior lower region. So you can appreciate the pleura. There is sliding. It looks thick and irregular, but mainly B lines and PA lines. And you can appreciate this is the liver. This is the right side, the liver. You can still appreciate the effusion. And then this small area with this thin rim, and I thought this was more of a pleural effusion because of this thin rim. You can see
it's a little bit tricky. I mean, the question is, are we seeing the liver with ascites and lung with diaphragm in between? I don't, I mean, a little bit tricky. It's a little bit tricky. Just give me a feel of an effusion because you have, my feeling is what you're seeing is that small rim there. If you just, that is probably margin of the diaphragm. And I just wonder whether you've got an ascites there.
Yeah,
which basically, we call this the floating liver sign. So the liver looks like it's floating.
Yeah.
And the classical example is ascites, but the other is like if you have a significant EP and extravasation. And it's just whether that is the diaphragmatic margin that's coming in there. And you have what I would call a mirror image artifact. Can you see the rib? So I just wonder whether you have a little bit of a mirror image artifact there. But the right side, the pleura looks pretty, I would say, a little bit blurred, but in moving, sliding, definitely. No evidence, to my opinion, of a proper subpleural consolidation, mainly a AIS kind of a pattern where the B lines have completely coalesced, maybe one A line coming in between. But I just think that area there is maybe a mirror image artifact, and then you just see a rim of diaphragm which is pushed up. It's often quite tricky, and I might be wrong, but I'm just having a guess. Yep. But well done. Nice image. Yep.
Okay. And so more, I'm trying to move my probe laterally, just to see more of the long views. I started this by trying to exclude the pneumothorax because the team were not entirely sure, and I could say the pleura sliding all the way through. There was definitely no more pneumothorax, and I could say that very clearly.
Yep.
But it's still more of a B profile here also. Yeah.
So again, just points that, like, the question is this a pleural effusion versus is this ascites? And the points against a pleural effusion are you don't quite have a jellyfish sign where the distal pleura, the distal lung, there should be some separation of fluid and you should see pleura there, but actually you see a very sharp margin with a sickle-shaped margin even here. So I just wonder whether that might actually be fluid in the abdomen as opposed to fluid in the actual lung. But very nice penetration. I mean, the depth in your images, Doris, is beautiful. I can see up to 4 centimeters, very uniform appearance. You might just want to turn your gain up just a little bit to get a little bit more kind of, Or, you using a frequency of here?
I dropped my frequency 7. I think I was 7.
Yeah, that's good. That's good. It gives you good interpretation. Very nice. Very, very nice. Yeah, there are some comet tails as well visible.
Yeah, that's a comet tail.
No evidence of a pneumothorax so far.
No, I clearly see that. I clearly see that. Yeah. Right. So this is the posterior view taken at the posterior axillary line. It was a challenge because of the way the baby was positioned. It was just difficult for me to get a better view, and so I tried as much as possible to angulate my probe. It was just so edematous and with massive ascites.
So these are beautiful images. What do you think you can see?
Yeah, so I was worried that maybe it was the way I was angulating. I was holding the probe, but I see this that makes me this area think about static air bronchograms.
Very good.
Yeah,
So
static air bronchograms. Yeah.
what you can see is, I mean, in inspiration, right upper posterior, the pleural line gets established. The static air bronchograms become less dense.
Yeah.
And there is an element of consolidation there as well. And then when the baby expires, what you've got is lung basically, the pleural line disappearing because you have atelectasis and you have static air bronchograms. And can you see that in expiration? This gives you more of a tissue sign. Can you see, especially in your right upper posterior zone? And it typically reflects the fact that the posterior areas of the lung in a baby that's supine are not recruited. And this is where, say, for example, if I was struggling with ventilation, I would think of doing a recruitment maneuver and observing this area, gradually increasing the PEEP to the point where in expiration as well, you'd be able to see an established pleural line without atelectasis.
Yeah.
So this is an absolutely beautiful image. Everybody, can everybody see this? Does anybody have any questions about this image?
Can atelectasis have a pleural line during inspiration? Because
absolutely. So, atelectasis can be dynamic. So what I'd say is that, look, the reason for atelectasis in the lung is multifactorial. Now, if you've got a complete right mainstem occlusion using an endotracheal tube, air can neither move in nor move out. Now, when air can neither move in nor move out, no air entry, you will have absolutely no pleural line because you can't aerate that lung. So actually, in those situations, what you see is those last large areas of collapse consolidation atelectasis, which have no pleural line. But in this situation, what you've got is low pressure, which means the posterior areas of the lung, they're not recruited. And really, like a very good example is, look at the image on the right, which is right upper posterior. So when you expire, there is air that's trapped in, which is the static air bronchograms in the middle. So if Doris just takes that area there, but when you inspire, can you see how the static air bronchograms move forward and establish the pleural line? And this basically just indicates that this is not complete obstruction of air moving in and out of the lung. This is really lung that is less well recruited. And just again, another example that I'd like to give you, you have a B profile coming in at the top of that image. And do you remember when I said, when you have atelectasis, you get these parallel linear air bronchograms. And in the lower part of the image, so Doris, just the lower part of your image, can you see those parallel linear air static air bronchograms? These are classic signs of what is quite a large area of posterior atelectasis, which is dynamic. It's dynamic because in inspiration, you're getting enough pressure in the ventilation for air to come in. But in expiration, the lung is just completely collapsing. And really, for a baby like this, the recruitment maneuver is increasing the PEEP to the point where the pleural line remains established and you don't see collapse. And that really is your point of maximum recruitment. And then you go back to the point of allowing the lung to collapse completely, so that ideally you're not seeing the pleural line. And that is your point of minimum recruitment, that pressure. And then what you're doing is basically using a pressure that's mid-ground between that. So, these are very nice images. The challenges with looking at the posterior regions, can I just say that Doris is looking at this through the posterior axillary line, so don't underestimate the challenges of getting a pleural line and seeing this. Well done, Doris.
Thank you.
Thank you.
Lovely.
So I moved on to the right side, scanning from the right posterior axillary line. So you can appreciate the difference on the right side.
Yeah.
Well, still a B profile with more lines, and then moving the probe also a little bit to get more of the view. Took me to the area of just at the cusp of the abdominal organs, which this was like the spleen, like we talked about.
It must be liver, because you're right.
Oh, sorry, right, not left. Sorry.
Yeah, that's all right. Not a problem. That's okay.
I still appreciate the ascites and the pleura coming into view.
Yep. And there you can see a very small pleural effusion. It's minuscule. And what you would call is a small jellyfish sign. So there's virtually a rim of fluid there. No. Just below that. Can you see the lung move in and out of that triangular area? Go right to the top. Go right to the top. Yeah.
Yep.
Go 1 centimeter to your right. Just there. Can you see that triangular margin? There's lung going in and out. So that is just a rim of fluid that's separating the visceral parietal pleura, and you've got a small jellyfish sign moving in and out there. So very nice. And that is subfluid in the subcapsular space. You have a little bit of an ascites.
Yeah. Okay. Yeah. So following on with that, so I was able to tell the team categorically there was no more pneumothorax, and they took out the chest drain, and we just continued managing the baby. Day 11, I repeated the long ultrasound. Baby was still ventilated at this point. Still had massive ascites. We had done an ascitic tap on one occasion, and another one for a therapeutic tap, a therapeutic and diagnostic tap. Still massive ascites, but the FiO2 was slowly coming down. We had changed the mode of ventilation from PCAC to SIMV because baby was breathing. So I did a follow-up scan on day 11 of life. At this point, the pressures.
So what was your indication? Why did you want to do the follow-up scan?
So I did the scan. One, mainly because the baby's oxygen requirement had come down. Baby was having some spontaneous breathing. We're not entirely sure whether we should attempt to extubate the baby because the baby still had massive ascites. The lungs were still looking small compared to the ascites, but baby was breathing. And I was of the opinion that, you know what, I could possibly extubate this baby, but the baby had not had a chest x-ray. So I wanted to do a long ultrasound instead of an x-ray to see to be able to check the progress, because I had done the first scan and to compare and to guide whether I would bite the bullet and extubate the baby, because I was.
That's fine. Carry on. Yeah.
So starting with the right side, this is the scan. The pleura looks less thick. It's continuous, looks thin, there is sliding. You can appreciate some comet tails, but you can appreciate A-lines, more A-lines than previously seen. So I put this down to an AB profile, and I was wondering if there was a double lung point here, because I could see clearly A-lines and then the B-lines.
Yeah.
I don't know if I'm right. Am I right?
No, you're right. You're right. That's correct. Theoretically, most people, when they talk about double lung points, it's usually aeration in the upper part of the lung and TTN kind of. But now we know that actually differential aeration can take place in kind of, especially lungs where there's healing. So you have definite aeration, an AB profile, and what you'd call a double lung point, comet tails as well. Very nice. Very good depth penetration all the way through. Yeah.
Yeah, this was on the right anterior lower area. Oops, where's my arm? Okay. And then, so scanning the left lateral, the left? Okay, yes, I started with the left anterior. Then, just a minute, let me check and be sure. Yeah, I've got the right one. So this is the right anterior lower, and then the left anterior, the upper region. So I just tried to be opportunistic and scanned as I could. So you can appreciate on the left side, yep, the pleura is continuous. There is sliding. You can see A lines, and but you can still see B lines. And I think the B lines are more than the A lines coming into view. And so I just put this down to a B profile.
Yep.
Also. All right. So going on to the left anterior lower region. So on the left side, as you can see, the pleura is continuous. There is sliding. Lots of comet tails. So I think this is more comet tails than subpleural consolidation.
Yep, I agree. I would agree. Yep.
You can see, I think there are more A lines here. You can see B lines with few. So I think there are fewer B lines than A lines. So I put this down to an A profile. And I thought there was a double long point here too. And interestingly, on the right side too, the right lower anterior lower side, that's where I saw the double long point, and the left anterior lower side too. Yeah, the double long point. Yeah, sorry, just a minute. Okay, so sorry, I'm being called now.
No problems. So what we might be able to do is continue this maybe next time. But it's beautiful images, and thank you so much. I'm really grateful.
Thank you. I'm so sorry for cutting.
No, it's okay. It's perfectly all right. Thank you. We've got Kenaz. Kenaz, are you able to share your screen?
Yeah, look, just give me a minute.
Sure.
So as I said, I'm having issues with the videos, but I'll try.
Let's see what we
Just
can
give me
see.
a
That's,
Yeah.
everything is good. After Kenaz, we've got Dr. Leila and then Dr. Rana and then Dr. Zaruddin. Very nice, Kenaz. Clearly visible. Just go to slideshow, master. Yeah, lovely.
Sorry, I don't know why it's blanked out. I went into slideshow.
Just escape again. Try playing escape.
It's come back, hasn't it?
Yeah. Just
I'll
try
try one
once.
more.
Yeah, one more time. Otherwise, we can look at them just as.
No, sorry, it's
No
not.
problems. So why don't you click on image 2, just slide 2, and we can have a look. And then slide 3. So that's fine. So why don't you present this way? Yeah.
Yeah, sorry.
Yeah, no problems.
Even though
This
they're not
works.
working, and I just have to apologize that my images are not brilliant because, as you know, for the only last week I've managed to get a lung preset and the zones and everything in. So the first 3 cases are only one side, so I've only got 3.
Relax. We're starting out. Yeah.
Yeah, thanks. So the first case was a 37 plus 5 weeks baby born by elective section. Had some respiratory distress at birth, so needed admission to the neonatal unit and was commenced on non-invasive ventilation. So we use high flow on our unit.
Yep.
So I hope everyone can see this image. That's the chest X-ray. And so then.
Age?
So this
Sorry.
is what? Sorry, what?
What age was the chest X?
Sorry, did someone say something?
Yeah, just asking what age the X-ray was done at.
4 hours.
Okay, lovely. That's fine. We can start with your images. Yep.
Yeah, I'm trying to zoom them, but they are not.
They're visible. So if you just play them, yeah. This is fine. So I can see.
R1, R2, R3 it will be. So can everyone see? I think it's quite small, isn't it?
It is small, but I can visualize definitely what I can see is you're using a sector probe with a pleural line.
Yes. So,
yeah.
So this is a sector probe C8 to 5.
Yeah.
And this is the probe that we were trying to, establish, trying to use it. So what I could see is I can see pleural sliding.
Very good. So can
and
I?
I can see, and I can see A lines and sort of some B lines as well.
So you're right. You've got in the middle, you've basically got an A line profile in the middle, right there.
Yes. Yeah,
yep.
This one.
Next to that,
yep.
on both sides, you look like you've got basically kind of an AIS kind of pattern. The pleural line is established, but you have an AIS pattern. So what would you think this represents?
So this would represent more fluid.
Yep.
So
yep. So AB profile, possibly a double lung point. Yep.
Yeah.
Very nice. So let's see your second image.
I'm sorry, I've got the sound on all of them. I don't know why again.
No worry. Okay. Beautiful. So very nice.
Oh, okay. I thought this one was not a good image. That's why I've
No, it's a very good image. So can I just ask, is this the left or right?
This is all right.
Okay. So what can you see?
I can see the heart coming in, isn't it?
Yes. So there is heart coming in, which is why I was kind of asking whether it's left or right. But what else can you see?
So I can see a lot of A lines, and these are A lines at the bottom. I thought it was not a good image, so I, to be honest, didn't.
My gut feeling is you've got heart coming in there, but what you've got is dominant B profiles. It's very difficult to see the pleura here because.
Yes, that's right.
So are you using the same probe or a different probe?
Yes, I was. But as I said, this is just like the first baby that I was trying it out.
Yeah, no problems.
So,
So can you see the top of your image? Now, look, when you look at the top of your image on the left, you can see that the
yes,
sector basically identifies the pleura. But what's happened over
yes.
here is you've probably increased your depth. And because you've increased your depth, the sector width has reduced, and your kind of your arc has become much wider.
Yes.
So what I'd suggest is what you need to do is reduce your depth a little bit, so that can you see me, Kenaz?
Yes, I can.
So that you've kind of got maybe a smaller zone, but a wider sector width. And then what you're doing is you're basically taking cut sections. But here, what I can see is a lot of B lines. If you just play it again, there's a very nice image that I want to show my colleagues. So can you see how these are B lines that are diverging, that are going through? But there's one image over here where the B lines diverge just when you press pause. So stop. Okay, play again and stop. There. Just stay there. Yeah.
Sorry.
That's all right. Okay. Just stay there. So no, we've missed it again. So just play. Okay, stop. Yeah, just leave it there. Now, in the middle, take your arrow up. Yeah, just to the left, to the middle of that, to the left. Yeah, there. What you can see is these horizontal lines that go all the way down to the bottom. These aren't A lines because they don't stretch through the top of the lung. These are actually Z lines. They're pseudo B lines. Again, they're a representation of interstitial fluid. So play the video. So if you just play it again. So there, can you see that?
Okay, these lines coming in from the top.
Yeah, but they're horizontal. Some of them, can you see? So that is a pseudo B line or a Z line. There. Can you see that? So just let the video play to the end and stop. There. So play it again.
Okay. To be honest, I didn't know what those were. That's why I moved on
Yeah,
to the next.
there. Can you see that line there? Yeah. Now that it's stopped, can you see how you have, these aren't A lines. I just want to get people completely clear with that. They go all the way to the bottom. They're not continuous like you see in a B line. This is classically what you call a pseudo B line or a Z line. Again, they're a marker of interstitial fluid, but in themselves, if you see an isolated line like this in one area without this appearance, it's not a B line, is what I want to say. And often you'll see them with sector probes as opposed to seeing them with linear probes.
Okay.
And the reason for that is basically ultrasound waves tend to diverge when you're using a sector probe as opposed to going linearly. So in terms of kind of reflecting back to you, you often get a kind of a diverging kind of an appearance where you get these horizontal lines extending all the way to the bottom. These aren't compact B lines. They are what we call pseudo B lines or Z lines. Okay, let's have a look at your next two images. Very good images today, guys. And Keras, these are good images. Please, don't worry. You're getting some really good stuff. So again, beautiful. What can you see over here?
So I can see the pleural sliding.
Yeah.
It looks like very normal thin pleura.
Okay.
And I can see B lines, but I can see some A lines. Again, now, as you said, are these actual A lines?
So they're probably A lines that are broken. The pleura is definitely sliding everywhere. And then you kind of have what I would say is maybe a little bit better aerated lung at the top with less well aerated lung at the bottom. So again, this could be a double lung point that is visible with the baby inspiring and expiring. I think if we were a little bit closer, the question I'd ask is whether you have a little pleural effusion there. So when you present next time, what I'd like us to do is it's going to be a slide. It's going to be an image per slide, magnified as opposed to 4 in one page.
Okay. Yeah.
Lovely. So let's have a look at your last image.
The problem is, Alok, I had to take videos of it from the packs.
That's good.
Then
That's good. Yeah. Can you see how?
Yeah.
I mean, this is good, Keras. Trust me. I think what we can do is interpret very nicely. And again, just for all of my colleagues who might use a sector probe, can you see how when you increase your depth, you reduce the sector width, which kind of means you lose your pleura. So it's in the fourth image. Play the fourth image. So it's very difficult to see your pleura because your depth has been increased. What you need to do is reduce your depth. And if you look at images 1 and 3, they are beautiful. And the reason they're beautiful is because I can see the pleura all the way down. Don't worry about sacrificing depth. Let's say you get 3 centimeters, even 2.5. I think if you're trying to dive,
yeah, if you see the video that's carrying on, I've tried to get a bit of the pleura.
Yeah, now I can see. Yep.
Yeah.
Now, yep, beautiful. Yeah, you can see the pleura very nicely there. Again, a B profile, dominant B profile here. I'm not seeing maybe some A lines on the
dominant
left.
B profile, isn't it?
Yeah. Very good, Kanaz.
Oh, thanks.
And I agree with the diagnosis. So it's transitioning lung at the moment.
So this looked more like TTN. This is a case that I would like to discuss actually. 34-week gestation baby, PPROM, maternal GBS positive, so strong risk factors for sepsis. There was a paternal history of methylmalonic acidemia. Poor condition at birth, needing resuscitation, was intubated and ventilated and given 1 dose of Curacif in theatre. And there was some concern regarding pneumothorax. This baby got extubated at 12 hours. So I wasn't there. I came on sort of later on. So this is the X-rays at birth following ventilation. So any thoughts?
What does the audience think? Anybody want to have a go?
Bilateral pneumothorax.
Very good. Yep. And
maybe pneumotostenium as well.
Very good. I would agree. Yeah. Classical sale sign.
Yes, that's right. Yeah. So essentially, what my dilemma was when I came on, this baby didn't have a chest drain. There was no respiratory distress. Gases were okay with good CO2 clearance. Baby was in air on minimal settings. And we were nearly 10 hours old. So I thought it would be a good opportunity to try the lung ultrasound.
Well done. Very good. Yeah.
So this is again the left side because, as I said, I wasn't sure about the probe and everything. So I'm trying. So this is L1.
Okay, sir.
So it was difficult for me to see whether there was lung sliding because I thought at some point that you could see a lung sliding.
Yep, I would agree. And you've got an A profile with the occasional B line coming in.
Yes, that's
now,
right.
My question is, if you were confused, what is the best thing to do?
M mode. So I did put it on.
Yep.
That comes. Sorry, I just one minute. Yeah.
Very nice M
mode. Can you see it?
Yeah. What do you think?
So I thought this was a seashore sign and not the barcode.
I agree completely. So you have sliding, and at least in that region, there's no evidence of a pneumothorax. So just remember, a pneumomediastinum might not be diagnosed. You're often not able to make a diagnosis of a pneumomediastinum using lung ultrasound. For sensitivity, there is, as Mayank Priyadarshi had sent an article, where you can actually go just lateral to the midpoint of the sternum and direct your probe when it's kept longitudinally to try and see if you can see air behind the level of the sternum. But at least in these images, what you've got is well aerated lung with the pleural sliding and a seashore sign. Very good. So again, I think the reason I'm really carrying on with wanting to emphasize, can you see everybody how you don't need a linear probe nor a hockey stick to get good images and make a diagnosis? You can do it with a sector head ultrasound probe if need be. Well done, Kenaz. Let's have a look at the others.
So this was L2. I don't think I've got a good picture of this.
Well, I can see pleura, and again, I can see what is an A profile.
Yeah.
The pleura
I
is a
thought
little
there
bit
was some
irregular because your
Yeah.
probe is not exactly at 90, and that is a challenge.
No.
Yep.
Yeah.
But actually, I can see an A profile. Again, what I'd say is that if you're confused about sliding, which can be the case, just put the M mode on and try and see if you can see a seashore sign. Let's see.
Yeah, that's what I did. That's what I was doing.
Beautiful.
So I thought this was still seashore and
Yeah,
not.
I agree. Yeah. Just
Sorry,
on
this
the-
is only an image because I could not get it to take a clip, so I just
That's
did
all
a
right.
video of it.
That's okay.
Yeah.
That's good. That looks like a seashore sign. Maybe on the right, and this is where you have to be very careful. There's a slight transition. Now the question is, have you
This
lost
way, isn't
contact?
it?
Yeah. Have you lost contact there? Or is there an absence of gel? And that's where I'd say that if you find this kind of transition and you think there might be a lung point coming in, it's probably wise having a long clip at this point. And a long clip kind of means that what I'd normally do is I would increase the number of seconds to save the clip, because it just means I can see that on the scanner, you'll keep watching this for a long time. But medico-legally, what you really want to do is keep a nice long clip so that people can actually see it. But I would say that at the moment I can see a seashore sign, and on the right, that transition, can't be sure, but yep, let's have a look at this.
I did see it on the machine for quite a long time.
Yeah.
So this doesn't have it. But that's what my doubt was, whether it was coming in. So I did play it. I don't think I've got a video of that.
No problems.
But this was just L3.
Okay. What do you think?
So I thought the pleura was sliding, and then there were some A lines with B lines as well.
Very good. So AB profile?
So AB profile, yeah.
Double lung point?
Yes.
Well done. Well done. Beautiful images.
So actually, I then extubated the baby.
Well done. So can I just say that what is very important again for everybody, we don't have evidence of a pneumothorax here, but you don't make a diagnosis of a pneumomediastinum using lung ultrasound traditionally. And if you look at the AAP recommendations for use of lung ultrasound for diagnosis of a pneumothorax, they said that they tended to underdiagnose pneumothoraces in babies with respiratory distress. They were missed. Actually, the cases that they've included represent air leak syndromes, which are pneumomediastinums. So, what I'd say clinically from your perspective is that having a chest x-ray, if your baby's not getting better, there's no harm, especially if you think your lung ultrasound doesn't show those appearances. So there will be situations where you might want to still do a chest x-ray. But overall, if you had done this lung ultrasound and the baby was clinically stable and you extubated the baby, I don't think clinically there would have been a problem. If the baby then deteriorated acutely, my advice would be to repeat the lung ultrasound to make sure that you have not had a pneumothorax. So very nice.
Yes, I mean that was my plan, because there was no indication clinically that the baby had a pneumothorax.
Sure.
They said low ventilator setting, so I just removed the positive pressure ventilation to see what happens, and the baby just got better.
Can I just, because we've got a few more people to present,
sorry.
Will you be able to present the third case on Sunday?
Okay. Yeah. I've got 5 cases actually. Yeah.
Okay. Should we do 3 of your cases first? You'll be first on Sunday.
Okay. Yeah. Sure.
But can I just say, just keep doing them. They're beautiful. And there's a lot
now,
of really
as I said, I've got my next 2 ones. I've got all the 6 zones. So
and please save your logbook, and I will send you your certificate on Saturday morning. I promise. This time I won't lie to you. Yeah.
Thank you.
Okay. Dr. Leila, would you like to share some?
Sure.
God bless you. Thank you so much. So Dr. Leila works with me in the department at Cornish Hospital. She's one of the senior consultants.
Okay. Share. Do you see my slide there, Alok?
Yes, we do. We do.
Excellent.
Thank you so much.
It is. Okay. So let's go from the beginning. So I use GE machine probe frequency 11 to 9 and using depth of 4. This is a 3-month-old baby, preterm 35-weeker, IUGR 1.6 kilogram, currently 3.4, and he's around 48 weeks critical station age. This baby was diagnosed antenatal with cardiomyopathy, a possible mitochondrial disease. He's still in oxygen, nasal flow. In the last few days, been requiring more oxygen and had to go and do PAP. So actually, the team asked me to look and see if there is any pleural effusion. So these are the first slide. I put my probe on the R1, and this is what I get. I tried really hard to go, right, left, up, down, trying to find the pleura, and I was not able to do that. Same, this is just going near to the heart, and still I could not find any of the lung artifact.
Yep.
Okay. Just continue doing this in R1. Now I came near to the heart, and I could see fusion, but I'm still not sure if I'm looking into pleural fusion or something else.
So, very nice images, Dr. Leila. So just from our perspective, R1. So your previous image, if we just go to the previous image.
Sure.
So we're quite high up over here.
Yes.
And what I can see is the batwing sign, but it's very difficult for me to delineate lung from what we're seeing over here. So again, what you've beautifully done is you've gone to your next images to try and establish a batwing sign. So let's just go to the next image.
Okay.
Yeah.
So
So what can you see at the left upper end, opposite to? Beautiful. So that's thymus. You've got a batwing sign, and then what you've got below that is
heart.
Very good. So heart, which looks very hypertrophied, massive hypertrophy.
Okay.
So a hypertrophic cardiomyopathy. And I mean, the fact that you can see heart on that side always kind of makes me feel that have you got a door-to-door heart? Because you're on the right side in R1. So you probably have a very large heart at this particular point, which means that it's not going to be easy to see lung. And around the heart, I mean, the question that I would ask is whether you have a small pericardial effusion.
Okay.
Yeah.
So here, Alok, we just trying to go more to the right side of the patient.
Yeah.
Okay, so left for us. And you could see again thymus, and I could see more pleural. Well, I thought it was pleural fusion. Maybe here this is maybe a pleural line, but I'm not sure.
It could be pleural effusion. You're right.
Yeah, okay.
Because it's below the thymus now.
Yes.
And you have heart that's coming in. So that could be a significant pleural effusion. Yep.
Okay. So next slide. Now I'm in R2. And you could see here pleural effusion maybe. This is near the liver.
Very good.
And I could see lung tissue here.
Yep, very good.
Fusing here, and this is the liver.
So again, you're right. You can see pleura right at the top. So a batwing sign with 2 ribs right at the top.
Yeah.
And then you can see the pleural line right at the top. So if you just go to the top, below the ribs.
Sorry, here. Just want to get rid of that.
Don't worry. Yeah, beautiful.
Sorry.
So right at the top, you can see the pleural line just under the ribs.
Yeah, and over here.
Yeah. I think the question that I'd ask now when I go to your last image is I am seeing a small pleural effusion there. Just at the level of the diaphragm. It's not massive.
It's not massive.
It's not massive. So you don't see a big jellyfish sign there. So, yep. Let's have a look at the next image.
Okay.
Yep. I would have expected to be a little bit big, but we're going to move posteriorly. So this is R2 as well.
That's R2, yeah. I'm just trying to move up and down, right, left. So I think this is near, I'm coming near to the heart here.
Yeah. I think you're coming near to the heart, and the heart is coming in the way, which is obscuring the interpretation of the lung. And really what you're seeing is basically the heart cavity. So
Heart
it's,
touch. Okay.
yeah, because you
Okay.
probably have a door-to-door heart.
Okay.
Yeah.
Okay.
Yeah. Massive
And,
cardiomegaly.
and that's the same. You could see lung tissue here coming in
Yep.
between in the third one.
Very nice. So in the middle, you're absolutely right. You can see lung tissue coming in between. And again, what I suspect is probably shadow from the heart or possibly the heart. I think you have a massive cardiomegaly, which is making it challenging. Yeah.
So
Again,
next,
just going back to the previous image, we go back to the previous image. I think in hindsight,
so this one here, or sorry, this one here.
Yeah. I mean, I think you might have significant amount of fluid around the heart.
Okay.
Yeah.
So, and then I just moved to continue.
Yep.
R3 and R4, I'm seeing more lung now.
Yep. Very nice.
Beautiful pleural fusion. I mean, not normal pleura. They are thickened. They are slightly maybe subpleural consolidation.
I would agree.
Line
Yes.
between, but mainly V-line profile.
Very good. Very good.
Yeah.
So very nice depth penetration, Dr. Leila. You're at nearly 5. Very uniform appearance. So very good. Yep. So,
okay, so
bat wing sign with a pleural sliding. Yes. Yep.
Yes. And then, okay. Now I'm going to the left side. Again, the same thing. I couldn't really see any lung artifact. You could see the pleural fusion. Well, I thought it was a pleural fusion here, or maybe pericardial.
So what you've basically got is you've got heart in the front, anteriorly, massive cardiomyopathy, which means
So
that
this
anteriorly it's very difficult to see lung.
Okay.
Yeah.
Okay. So what I'm seeing, this is going to be the spleen, or?
That's correct.
Okay.
Very nice images, Dr. Leila. Can I just say your image anatomy? So at 4 centimeters. Yeah.
Well,
You definitely have a
Alok.
pericardial effusion. There's absolutely no doubt. It's not massive. Yeah. No, not at all. So yeah.
Yeah. Really, I mean, it was very confusing, but listening to your lecture, it was easy to understand. Again, L3 and 5, you could see normal lung tissue, well, not normal tissue, but lung tissue, I should say. Pleural sliding, comet lines, so maybe a AB profile, and then maybe subpleural consolidation.
Yep. So dominant B profile with subpleural consolidation.
Mainly profile, yeah. Okay.
Yeah. So I think another really good message, what you've basically got anteriorly, the difficulty with seeing lung tissue is a massive door-to-door heart. And most of the lung tissue is basically seen in the L3 and the L5 regions because of that. Yep.
And just our point, yes, I tried to do the 4 chamber, and you could see the fusion over here.
Effusion. Yeah, very.
Fusion. And then this is the parasternal longer, and you could see huge here fusion.
Pericardial. Yeah, it's
pericardial fusion. Sorry, yes.
That's all right. That's all right. Very nice images, Dr. Leila. Yeah.
Thank you.
Massively hypertrophic. Yeah.
This is the X-ray.
Yep. Door-to-door heart. Yep.
Just wanted to share with the group.
It's a very nice case.
Thank you very much. Thank you.
Not at all. And just again to highlight to the group that, if you see images like that where the heart is coming in on the right-hand side, think of the potential for cardiomegaly, think of the potential for collapse on that right side, pulling the heart to itself. Or you might have a decent sized pleural effusion on the other side, which is pushing the heart onto that right side. So some differentials and a dextrocardia, as we've seen with, images previously. So thank you so much.
Thank you. I will stop now.
So the next presenter would be Dr. Hassoun.
Good afternoon for everybody. Just 1 second.
Thank you so much. And then we'll have Dr. Rana.
Is it okay? Sorry, hello. Can I present on Sunday, please?
Is that Dr. Rana?
Yeah, it's me.
Yeah. You can present on Sunday, Dr. Alia.
Yeah, sorry, because my slides are not ready for today.
No problems. Absolutely fine. Absolutely fine. So, we've had some beautiful cases. And can I just say that you're all coming on really nicely? Again, just while Dr. Hassoun is preparing, you can use a sector probe and you can get good images. Go for it, Dr. Hassoun.
Thank you. So this is a term baby, C-section for tender scars, multi-gravida woman, JBS negative. He got respiratory distress, admitted to SCABU just for observation at the beginning. He got high flow of nasal cannula, then upgraded to NCPAP with pressure 6 to 7, FiO 2.4, and finally intubated and surfactant given by 5 hours of age. This chest X-ray has been done and showing picture of RDS versus pneumonia. We could not say on the X-ray, and I had the opportunity to do this lung ultrasound at 50 hours of life because of persistent oxygen requirement up to 50 and high ventilator setting. We got second CRP was 20. So for us, it was pneumonia clinically. So, but just we did this ultrasound to see what this lung will, what we have on this lung ultrasound. So on L1, we have good sliding, almost normal pleura with some B line, with A line also, and some subpleural consolidation, so mainly AB profile. The R2, same, good sliding, in pleura, and more B line with AB profile also. So, and there is, at the beginning here, maybe there is one subpleural consolidation, but nothing otherwise. R3, posterior zone. So here we have still good sliding with pleura, little bit thick with subpleural consolidation. Look like double lung point, but it's when we did complete the study, for us it was more on favor of pneumonia. We will talk about it.
Yeah, sure.
So
sure.
this is R3.
Just to mention, you have a beautiful machine, sir. You have a beautiful machine and the images are beautiful. I mean, can you see the delineation in this area where you think there's a double lung point of the B lines right to the bottom? They diverge, but they're separate. So, a lot of machines would probably interpret that as a compact B line, but your machine is not attenuating the artifact. So it's a very nice machine. Please carry on.
This is linear probe with between 12 to 13 decibel with 4 centimeter depth. The other one on R4, here the pleura, okay, looking thick, good sliding, many subpleural consolidation, and here if like some more subpleural consolidation, I don't know if we can call it shred sign here.
I wouldn't call it shred sign. No, that's basically subpleural consolidation with you lose your kind of again with expiration, what you're having is a little bit of atelectasis. And that's why what you're classically getting is it's like a snowflake sign, but what it represents is, it represents static air bronchograms, subpleural consolidations right at the top. So, and can you see how your pleural margin just falls away in expiration? So, with the eye of faith, it's a little bit tricky.
I think I have Doppler. I will show you that.
Sure.
So this is L1. Pleura is in many subpleural consolidation, small one, and B profile, mainly B profile, some A line in between, but mainly B profile. The L2, same, mainly B profile with some subpleural consolidation in the middle, still good sliding and thin pleura. Do you have any comment, Alok, on these two?
No, I'm just wondering whether you might have a very small pleural effusion or whether this is just artifact.
Okay, I didn't realize
might be artifact. No, I don't. Might just be artifact. Might just be artifact. That's fine. Carry on. Yeah.
So we'll go to L3 now. Mainly B profile with good slidings in the pleura, also some pleural consolidation. And when we go to L4, here also the same, but mainly also B profile, subpleural consolidation, and thin pleura. Here we got it on posterior one on the left side, this image. Here it is like static bronchogram.
Very good.
I didn't see the pleura. So for me, it looked like atelectasis.
Very good.
Just first time.
Very good.
But when I did the and also the other lung tissue looked like some pleural consolidation, and the pleura is irregular. So just I put the Doppler on this one.
Yeah.
and that's what I have. So sorry.
Yep.
It looked like, and on Doppler, it looked like pneumonia. I don't know.
No, so just what I'd say is that this is where, if you remember in my last talk, I told you that you have areas of atelectasis, and really what you should be able to see is a blood vessel-like appearance. Now, you can see some vascularity at the bottom. I agree. So you can see some vascularity, the blue at the bottom.
Yeah.
But actually, when you go distally, you can't see much. And that just reflects the fact that I'm basically going to send around a video that I'm making on atelectasis to you, that the areas of static air bronchogram or consolidation will have blood vessels or blood perfusion within them. But the distal area that you see where the pleural line is not established, on the left side, that is definitely atelectasis. And I think what you've got when you play the image on the right is the pleural line is established there. And that is probably because you've got this during inspiration. So for me, on the left-hand side, your left image, there's absolutely no doubt that you have atelectasis over there. You have no established pleural line with static bronchograms. And again, what I'd say is, if your baby was on a ventilator, this is the kind of area that I'd be looking at to kind of say, if I perform a recruitment maneuver, I'll maneuver it. But there's a difference with your image on the right side. I can see established pleura. On the right, yeah. So the question is, have you got that image when the baby's inspiring? There's still static air bronchograms, but the lung is just more recruited here. So was there a gap or a time limit, or did you increase pressure in between before you did the image, or was it done?
No, I didn't do the recruitment maneuver because it's a little bit to convince our team to go for it. But clinically for this baby, if again retrospectively after having all the picture now, clinical picture, CRP went to 20, then 30, and on X-ray worsening, and we saw pneumonia. So we consider this as pneumonia.
Yeah, I don't think that's unreasonable. And you remember I said that with groupie strep in particular, you often get a ground glass kind of an appearance to the X-ray. There's absolutely no doubt you have subpleural consolidations. Let's go back to the history. So just what day of age? This is at birth?
This is at 50 hours of age.
50 hours of age, okay.
So for 50 hours, because at the beginning I didn't have the opportunity to do it, but because a 50-hour baby still on high oxygen 0.5 and pressure about 25, 26, saturation also. We did also cardiac ultrasound just to be sure everything is okay. There is just mild pulmonary hypertension, and this CRP went up to 20. So in all the clinical picture, we consider it as pneumonia.
Yeah, I think that's very, very reasonable. My only other thought is, had we had a lung ultrasound earlier with serial lung ultrasounds, and if you had purely a picture of RDS with subpleural consolidations, and you've given Survanta, and now you're doing a follow-up X-ray. So especially in the anterior areas, there are some areas that look a little bit more aerated. There's that image with the double lung point. So transition, and then the posterior areas for a supine baby, which are a little bit atelectatic. So it could be treated RDS. It could be RDS with an element of pneumonia. And sometimes you get that mixed kind of picture. So, but actually, clinically, with that entire picture, I think we'd be very brave not to be on antibiotics, considering what we can see. Yeah.
But the other issue we did it. Sorry,
I apologize.
You. We did this ultrasound, so maybe 46 hours or 42 hours after Survanta. So what I interpret the result that we should not have double lung point or resolution after 40 hours of surfactant. So most probably we are ongoing something ongoing, a process is going on. So we consider it, we are thinking like this, and we consider it as pneumonia.
Can I ask, when did you do the scan? Is the baby still on your unit?
Yes, on timing, you mean?
Yeah. So this was done at 50 hours. But
50 hours,
how old is the baby at the moment? I'm just curious whether we can do a follow-up lung ultrasound on him.
Okay. Now it's transferred. We are a high turnover unit, so it transferred to MOH hospital.
That's all right. Beautiful images.
So can I present a second case if I have time or no time?
Yes, you do. I think Dr. Zaridin is the last person presenting today. So let's do a second case.
Okay, this is the same case. Sorry, go Alok.
Yeah, can I just confirm, Sharif and Rana are going to present on Sunday. Kirti, are you happy presenting on Sunday?
Yeah, I can present on Sunday.
I'm grateful. God bless you.
Alok, is there a place to present today? I have a really interesting case instead of Sunday, if possible, or if no one in the queue. I'm not sure.
I think we're gonna hit 8:30. Are you happy presenting on Sunday? Is that okay?
Yeah, of course.
That's
I'm just
so kind
asking.
of you.
Thank you, Alok. Thank you.
I'm sorry, Alok. I was counting to present today, but can I present only a thing that I have a doubt?
Yes. Okay. Let's do one thing. Let's be fair to everybody. Dr. Hassoun, can we present your second case? Yep.
Yeah. We can postpone it to Sunday, no problem.
That's really kind. So maybe if we get Dr. Zaruddin to present one case, we then get Anna and Dr. Sharif to present a case each. And that way we should be able to wrap up by 9. So next person could be Dr. Zaruddin.
Yes, hi. Can I share my screen then?
Yes, please. Yeah. And guys, we're going to have 2 sessions next week as well. So please don't feel worried. I'm going through a relatively reasonable phase at the moment where we'll be doing a lot of peer reviews. So please do share your cases, and I will be doing your OSAL forms as we go along.
Thank you, Alok.
Thank you very much.
Screen.
Visible.
Yeah.
Visible, sir. Thank you.
So thank you very much for giving me the opportunity, and I promise you it's not going to be long. It's a short one. So it's this is again our machine. It's a sonocyte, and this is the probe that I'm using, which is highlighted on the lung. So it's an extreme preterm baby, 23-weeker and 6 days, was born with an emergency cesarean section, kind of middle ground Apgars. Birth weight was 610 grams, and he was ventilated since birth. He came out not in a very reasonable condition. He's actually one of twins, a baby boy. His course is complicated. He's now over a month, and he's been ventilated since birth. He's had bilateral large IVHs with ventricular dilatation and clinical seizures, and he is on anticonvulsants as well. His course has been actually made even worse with E. coli proven sepsis, and he became very unwell with it. I did his scan on day 28 at the age of 4 weeks. At that point, he was on SIPPV with volume guided ventilation with a tidal volume of 4.6 milliliter per kilo. As a reflection of his poor ventilation, he is actually, and he was at that point, 100% FiO2. His oxygen saturation was hardly hitting the 90 mark, but when you touch him, he was just plummet down to 60s, 70s, 80s if you're lucky. So doing his scan was a bit tricky as well. And as you can see, his blood gases, he's heading towards chronic lung disease. He was sorry, that sentence, I think that's just but he had 2 doses of surfactant anyway. Yep. At the time of scan, again, he was muscle relaxed and sedated. He had an echo done and was showing a tiny PDA, so the cardiac element was really almost excluded. I'm going to start by his lung ultrasound scan, which, again, to remind you, was done at the age of 28 days. This is R1. It is showing a regular pleural line with predominantly compact B profile. Perhaps there might be some very, very occasional A lines, but it's mainly B profile picture. And again, to remember, this is at the age of 1 month.
It's a beautiful image. It's a beautiful image. Your depth up to 5. I can see uniform penetration throughout. You know, the pleura line is clearly visible. Good batwing sign. Very nice, sir.
Thank you. Thank you. And this is R2 going down. Again, it is again a fairly irregular pleural line with some subpleural maybe consolidation.
Such a beautiful image, yeah.
And predominantly again B profile. Some maybe A lines every now and then, but otherwise there isn't really much that I could see.
Agree.
Then I'm gonna just move on to the next set of pictures. This is R3 going down to the lateral side. Again, a regular pleural line. I think there is a airpromograms in the middle column of the B profile with some subpleural consolidation across the 3 costal spaces. There isn't really much that I could see there.
Just in your R3 image, you have static, very nice static air bronchograms, but then can you see there's a small dynamic air bronchogram right at the top, which goes in and out? There.
Here.
Yes, perfect. Just there. Yep.
Yeah.
That area, so I can't see an established pleural line. It's predominantly static air bronchograms with quite a significant consolidation below. Do you think that's atelectasis or consolidation as a whole? What do we?
To be honest with you, I think it's a combination of the two.
I would agree. Yeah.
He obviously as we are doing his scan, he is being treated for E. coli sepsis, which I don't think it has spared his lungs as well. So he is really very sick. I have at the end a little clip of him so that you can appreciate how sick he is.
It's a beautiful image in R3. The presence of dynamic air bronchograms usually favors mnemonic consolidation. So, you know, it's a beautiful image. Did you put Dopplers there by any chance, or was he too sick?
I'm afraid that I was so nervous with his saturations.
I understand. Yeah, no,
he was. So I was just glad that I managed to get some images. So I'm sorry about that. Maybe
no, please don't apologize. These are beautiful images.
Thank you. Then his R4 going down, again, a pretty much similar picture, although the air bronchograms, the atelectasis / consolidation is not as evident. It's mainly B profile with the same story of the irregular pleural lines. And then I couldn't turn him over. He was so behind. So I'm just gonna. I've only done the front pictures. So I moved to the left side. Again, it's pretty much mirror image of the right side, although the irregularity of the pleural line is more evident on the left. And you can see how broken the pleural line is with some subpleural consolidations, but it's mainly a B profile picture. And so is on L2, and you can see the tail end of the upper part of the L1. You see here, and then the bases maybe are a little bit spurred with regard to the irregularity of the pleural line, and then the heart just coming in every now and then.
Very nice.
And that is then moving on to the lateral side. Can tell he was very edematous at some point, that he might be having even necrotizing tuberculosis, his tummy so distended. Then you can see the irregularity again, pleural lines, subpleural consolidation, mainly B profile, I would imagine. And then on L4,
Mm.
same thing.
Mm.
You can see here irregular pleural lines. So these are the last two chest X-rays for him. One was done a few days. This one on the left-hand side of the slide, this was done about 2-3 days prior to the lung ultrasound scan. And you can see how knackered his lungs are. There is a bilateral patchy consolidation with irregularity. I think it's just a collapsed consolidation with probably lung loss of lung volume and destruction of the lung tissue. And then the X-ray, chest X-ray, oh, sorry, I just, that's his video. The chest X-ray on the right side, this was done around the time of the lung ultrasound scan. He had an elective re-intubation just after that.
Yep.
And you can still see how his lungs are not really good looking. And I think he's just heading towards a chronic lung disease picture with very fluffy lung appearance. I thought the ultrasound has helped me a lot in this is my reflection on the baby, but just before I give you the 30-second reflection, I just show you the baby. This is him, poor guy. That's while he was having seizures. So my really very quick reflection and actions based on the lung ultrasound, I actually increased the tidal volume, and I was really kind of brave enough to turn him on his tummy because he's never been nursed prone. And luckily we've had a better FiO2 requirement, and his saturation went up nicely. I wished I have done another lung ultrasound to see the reflection on increasing the tidal volume and changing the position as evidenced by the blood gases and the oxygen requirement, and also to be seen on the lung ultrasound. I may do a lung ultrasound in the coming few days if I have a chance, but he was clinically better when the tidal volume was increased from 7 to 8. His FiO2 went down to the lowest we hit 75%, which is really a victory for us. And his fat, we had 100% at some point. But he obviously he's very sick, as you can see. So that's him, and thank you very much.
So, I mean, beautiful images. I don't have much to critique, actually. You've got really good depth penetration. You've got a very nice, I would say, so I'm not just going to say your machine is good. So just for my colleagues who are watching this, doing a lung ultrasound in such an idiomatous and unstable baby to get the parallel nature of the pleural lines that you've got, the depth penetration, the accuracy of it, and what clearly, I've taken back from this is your left lung looks better aerated than the right, even though there's a little bit more atelectasis visible in certain areas. With what are classically evolving features of chronic lung disease. The R3 area, again, that could be mnemonic consolidation that you see over there, could be a collapse consolidation with atelectasis. And, again, it's the challenge of, how much you handle the baby. But I think the images are beautiful. I have no critique. And yes, I hope you're able to pull the baby through. And, if it's stable, for the recruitment with the tidal volume, it might not just be recruitment of that middle zone in R3, but you might be able to see that your B profile that you see with sliding gets converted into maybe an AB profile. I think the worry that I would have if you get a complete A profile in that situation is the risk that you might pop lungs. So the challenge from our perspective, and we're going to talk about patterns because you've got a very nice pattern there. Dr. Zaruddin, can I ask you for a favor?
Yeah.
Yeah, so we're going to do lung patterns again on Sunday, and I would be very keen for you to present the set of images again. So
course.
I just hope you're attending on Sunday, but what we have been talking about is S pattern recruitment, and it's very well visible in this slide. I don't want to go into too much detail because I know others are waiting, but yeah, very nice slides, sir. Thank you so much.
Thank you so much. Much appreciated. Thank you.
We now have Dr. Anna Vaz. So Anna, would you like to share your slides and then we'll see Sharif?
I can show only my doubt because it's not in the lung, but I was a bit scared with what I saw in the abdomen, and I don't know how to, because I was doing the lung ultrasound and I was going too low.
Yep.
And then I found air and I was a bit
okay, yes. Now you
scared. Maybe it's not
no,
nothing.
Let's have a look.
Okay. I can present the case in Sunday or next week. It's okay.
Yep.
I just want to show you.
We'll need the background to make a diagnosis. Present the case. We have time.
Yeah?
Yeah,
okay.
Go for it.
It's not long.
Don't worry. Take your time. So let's go to slideshow mode. Yeah.
Okay. It's okay?
Yes. Yep.
Okay. It's a 33-week boy, and he was intrauterine growth restriction, so he was under surveillance. And he did the ultrasound, and the blood flow was getting abnormal, and he was bradycardic, so it was a C-section from some urgency. And the baby really didn't born well. He needed reanimation in the delivery room with endotracheal tube and was transferred to the NICU after restoration in CPAP. And I was on the unit only on day 3 of life. He had mild respiratory distress and the FiO2 was a bit high, 30–40%, but he was on CPAP. The blood gases were okay. And I did lung ultrasound to see how the lungs are. And we can see in R1 that we have the clear bed sign with the ribs and the pleural line. It's a bit irregular, maybe the pleural line all along, and with multiple B lines. Some are more sparse, not so compact B lines, but it's a B profile.
Very nice.
And in R2, we can see a double lung point. Like Doris was saying, it's more A lines in the bottom that in the upper field, but I think we can say it's a B profile, double lung point.
Yep, I agree.
I was in doubt if this is a bit of fluid.
So again, what I'd say is you could lung kind of rather than giving the jellyfish sign or moving in and out.
Yes.
I think that's mirror image artifact. You often get it there, just from the rib. So that's one possibility. The other possibility, which I think is less likely, is whether that might just be occult atelectasis. I just think you have a little bit of mirror image artifact there. Yeah.
Okay.
Yeah.
Okay. And R3 is a B profile.
Very good. Such beautiful compact lines, Anna. Amazing. Yeah.
Coming down.
Yeah. Such beautiful compact B lines. Yeah.
I tried to do the breadth score, and I think this is a 2, maybe a 1 and a 2.
Yep.
So 5 in the right side.
Yep.
And the left lungs. Okay, let's see the left. L1 with the heart, but when the heart disappears, we can see that is a B profile with some irregular pleural line, but all sliding, and B profile, and L2 the same, and in L3 the same. So this left lung is more homogeneous.
Yep.
And I think we have a small subpleural consolidation here.
Yes, no doubt. Absolutely no doubt. You do have a small subpleural consolidation there.
And I think we have 2 in the breadth score in each lung.
Yep.
Scan. So the total of the lung is 11.
Yep. What age?
3 days of life.
3 days of life. Okay.
3 days. 33 weeks.
Yep.
I think like we have only this subpleural consolidation, and we have some A lines coming in and not so compact B lines. I think this is maybe I was going back, sorry, a TTN more than RDS. Clinically, the baby gets well without doing any treatment, although CPAP.
So can I ask this is the first lung ultrasound?
Yes, it's the first.
And just in terms of your FiO2 at 3 days, how much was it?
It was that was why I did the lung ultrasound. It was around 30 to 40, but the day after it went to 21-23%.
Sure, that's fine. I mean, if I was clinically correlating, I'd say that you only have one really good subpleural consolidation. Otherwise, the pleural line looks relatively blurred with more of an interstitial syndrome, as well as the compact B lines. Sometimes you can have a little bit of, I would say, an element of a mix of both. But actually, clinically, what you'd be doing from your perspective is kind of clinically correlating. So I think you're right, Anna. Yeah, I would agree.
I have the X-rays. This is on the first day, and this on the third day of life.
Elective cesarean?
It was elective because of the fetal not being well, with bradycardia and the blood distribution of the blood.
And you might have a little bit of delayed perinatal adaptation, and just even in those babies, just remember, some of them can actually have a little bit of pulmonary edema, secondary to left ventricular dysfunction, which prolongs that transition phase, which kind of means that sometimes TTN has a mix of a little bit of more of an interstitial syndrome, which you've clearly got fluid in the fissure there. So very nice lung ultrasounds, Dr. Anna. I'm very grateful for you sharing them.
And when I was doing the left sides, I was going to wow, and I found this, and I was a bit scared about this.
Yeah, this is not a pneumothorax. So what happens is once you enter into the abdomen on the left side, you get the stomach. And if the stomach has air in it, then what you will get is you will get a classical A profile.
I was in doubt if it was the stomach. It was my doubt.
So that is classically what gives you that artifact. And just be careful, guys. It's not a pneumothorax, but just be aware that free air in the abdomen can present with an A profile. Now, the way you make that diagnosis is normal free air in the abdomen will be in a supine baby under the level of the umbilicus, unless you have a massive, massive pneumoperitoneum. But the stomach will have air in it and is very close and can sometimes, especially if you're doing L2 and L3 regions, create a confusion where you think, is that a pneumothorax right at the bottom? And really what I would do is I would basically try and identify the diaphragm if possible. And I think what you can clearly see.
This is spleen, right?
Yeah. Yes, you're absolutely right.
Yes. So I thought it was in the abdomen. My doubt is it was stomach, because I think I never saw this in other babies. Maybe I was not.
So at birth, if you have an NG
maybe.
and there's air in the stomach, you will see it. But let's say you've decompressed the stomach completely. Somebody's put an NG down and taken all the air out, then you might not. But my gut feeling is what you're seeing is the abdomen, and you're probably seeing air in the stomach there. What you have to be very careful about is that you don't have free air. I think if you had free air, then what you'd really be looking at is air below the anterior abdominal wall. So I'd be surprised if I think that's just air in the stomach.
Okay. And I have the X-ray because we did it. We didn't. I was, and really we can see free air. It's the stomach.
Yeah, no doubt about it. Yeah. So just for free air, it'll be anterior, and as you move laterally, what I would suggest is that if you're doing an abdominal ultrasound for free air in a supine baby, just decompress the stomach, please, because it'll give you confusion.
Okay.
So what I'd say is just get somebody to decompress the stomach until you don't get the air out, and you're moving your probe from the center of the abdomen laterally. And really what you'd see is basically an A profile in the epigastric region. other things that you can use. I mean, eventually, there's no doubt you'll need an X-ray. No surgeon will ever go into that abdomen without you doing an X-ray. So you'll need an X-ray, but there's a very nice Twitter feed from POCUS at the moment, which shows you free air on it. I'll try and share it with you. But beautiful images, Dr. Anna. Thank you so much for sharing this.
It was not
case.
long, but I wanted to share with you. And I want to do the model of the ultrasound in the gut.
Yeah, so that'll be next year. So we have brain first, and then we'll have gut. So soon.
Okay.
Yeah.
Okay.
Thank you so much.
Thank you.
Sharif has kind of had to go. Is there anybody else who would like to share one more case today? We have time for one more.
I can go for another one if you like.
Okay.
Is Kirti? Should we let Kirti present one? And yeah, is that okay? Kirti, you want to share?
I don't have any right now.
You don't have any. Anybody else?
Alok, I can present Sujit.
Okay, well, let Sujit present one, and that way I've basically got OSAL forms for everybody. Can I just say the quality of the imaging is just amazing. I'm learning so much from everybody. I'm grateful for this opportunity.
Just wanted to have a comment. Thank you very much for that new piece of information. This is something new about this. I thought initially ectopic lung tissues in the stomach, but it's very nice to know that air in the stomach will give you the artifact with air very much like a profile. So that's thank you so much for this.
No, it's a pleasure.
We bear that in mind. Thank you.
Can you see my slide?
I can do, sir. Yes.
You can see case 26?
I can see case 26. Thank you.
Okay, fine. No, thank you so much for the opportunity. So this is a 29-weeker who is is sort of 6 weeks old, is an ex-23-weeker who's 1.2 kilos, is on invasive respiratory support. And needing sort of moderate amount of oxygen, known to have a large PDA with left-right shunting. And I basically did this to look at heart-lung interaction, scanned using a hockey stick probe at 8 Hertz. So R1, R2, so you can see the bat sign, multiple pleural spaces seen. So I'm sort of looking at thickened pleura with interruptions. There is some subpleural consolidation, tiny amount, and then slightly thickened pleura here, right?
Yeah, I would agree.
With compact B lines. Yeah, and then moving lower down, again, similar sort of picture of thickened pleural lines with compact B profile and maybe a hint of A lines that I can just about see.
Yep, very nice. Beautiful penetration, up to 4 centimeters, uniform image, batwing sign, pleura. I think your gain settings are very nice.
Thank you. So moving on, R3, R4. So I have again a thickened pleura with good pleural sliding, predominantly compact B profile. Just up here, I have sort of subpleural consolidation with dense sort of B sort of profile.
Yep, so I would agree. Yep.
And in R3, R4, I again have a similar picture, predominantly compact B lines with subpleural consolidation. And then R5, R6. So no obvious pleural line that I can see.
Yep.
I can see static air bronchograms.
Beautiful.
On a background of sort of B profile, compact B profile down below, and again sort of lower down R5, R6, similar picture. The pleural line is sort of absent.
Yep.
And then if you put color on that, so this is color compare. So I can't see any obvious.
Very good. This is a beautiful image, sir.
Vascularity,
Yeah.
Which is in keeping with an atelectasis.
Yeah, I would agree. Very nice images, sir. Yeah. And ideal for a recruitment maneuver if you tubed or kind of ventilated this region.
Yeah. And then on the left side, again, similar to the right side, thick pleura, which is sliding properly, predominantly B profile, a hint of A line seen there. And L1, L2 is again some A lines there, but predominantly B profile.
Very nice. Very nice. Yep.
Moving to L3, L4, I have similar sort of a picture.
How old is the baby, Dr. Sujit?
6 weeks, Alok.
Yeah.
Yeah. And L3, L4 again, irregular pleura, some subpleural consolidations, and this was the X-ray that we had.
Yeah.
So thickened irregular pleura, subpleural consolidation. This baby sort of had a slightly elevated CRP also, absent pleural line, static air bronchograms, in keeping with atelectasis, but I think there's probably coexisting infection.
I would agree.
Yeah, alveolar interstitial syndrome in this baby with a PDA and chronic lung disease.
Beautiful images. I think, in particular, the atelectasis, and classically from our perspective, there is areas of kind of, I would say, atelectasis posteriorly with an absent pleural line. No critique. I think they're just very nice images. And again, so it just gives you a good flavor of, if you wanted to kind of do recruitment or you had a baby against the wall, how powerful lung ultrasound would be. I mean, you can use X-ray as well, but the exposure, the plates, the handling to the baby. So my compliments.
Thank you so much, Alok.
No problems. I'm just going to thank everybody today and to say that, guys, it's more practice now. Sunday is the last kind of session with lung recruitment revised. I'm not going to be doing much in terms of teaching now, but what we're going to do is we're going to practice. You have cases, practice every week. Your L2 certificates will hit your accounts this weekend. So congratulations to all of you. I think you've done a fantastic job. Some of you have achieved your L1 status today. Kenna is amazing. I'm really, really happy. And again, I just want to emphasize, you can do lung ultrasound using a sector probe. So, well done for all the tenacity and effort that you've made to try and make this possible. And God bless you all. I'm so grateful for the experience of having to be able to see images with you.
Thank you so much.
Thank you so much, Alok, for your support. Thank you.
Bye.